organizers for giving me the great opportunity to be with you today. What we are going to discuss is the clonal hematopoiesis, and we need to know, do we have something happening before it appears? Do we have something prior to particularly myeloid malignancies and myelodysplastic syndrome that happens in the bone marrow prior to the appearance of the disease? We know that with aging, we have many visible changes, but there are some other invisible changes occurring in our body, particularly in the hematopoietic system. We do have an MGUS, monoclonal gammopathy of undetermined significance. We have increased incidence of monoclonal B-cell lymphocytosis, and recently we have identified the occurrence of clonal hematopoiesis of undetermined potential. So when exactly does this happen or start? Surprisingly, and to our astonishment and frightening as well, this starts in early life, even before early adulthood. And we could have the nidus or the seed for these changes as early as our life, as early as early adulthood. And this the current concept about the starting of these changes is observed when we have a change in the variant allele frequency equal to or more than 2%. In the Western perception and experience, the MDS is a disease of senior persons, but it can be presenting as a stormy scenario, particularly in our area when I experience a lot of very stormy course in young individuals, even in their 20s. So what are the genes which are recurrently mutated in myelodysplastic syndrome? The most important of them is the epigenetic regulators and the splicing factor, but we do have some variants in MDS and myeloid malignancies with JAK2 mutation, and a rising evolving rule of B53 mutation is now documented in all myeloid malignancies. The clonal hematopoiesis, the mechanisms driving dominance of stem cell is by many genes. The most important of them is DNA transferase, methyltransferase gene mutation, followed by TET2 and ASXL. And we can see that epigenetic dysregulation constitute around 71% of basic genetic mutation in myeloid malignancy, and this also occurred in the pre-hurricane phase or the pre-appearance of myeloid malignancy. Most of the mutations, or almost all the mutation in myeloid malignancy and myelodysplastic syndrome carries adverse prognosis, except the SF3B1 mutation, which is a splicing factor mutation. And as you see, the more we progress for a high-risk myelodysplasia and acute myeloblastic leukemia, the more genetic mutations we have. Particularly B53 appears when we start to have a high-risk myelodysplastic syndrome, and of course FLT3 appears with acute myeloblastic leukemia. We start by 2015 to identify the idiopathic cytopenia of undetermined significance, or ICUS, and a year later we start, and this idiopathic cytopenia of undetermined significance have been documented to precede some myeloid malignancy, particularly myelodysplastic syndrome, and then a couple of years later we start to identify clonic cytopenia of undetermined significance. This is what was thought of progression from ICUS to SHIP to clonal cytopenia of undetermined significance to low-risk myelodysplasia to high-risk myelodysplasia by 2016. And you can see that the clonality is present in all except in ICUS, and dysplasia is present only in myelodysplastic syndrome. In 2020, the situation has been a little bit changed. We start to speak about not clonality, but variant allele frequency. And once we have the detection of more than 2% variant allele frequency, we are in a clonal abnormality of myeloid progenitors, starting from the SHIP to clonal cytopenia of undetermined significance, and dysplasia, as we said, might not be present in the 3 pre-myelodysplastic syndrome phase, and we go down by bone marrow blast cell from 5% to 2%. So to consider clonal cytopenia or CHIP or idiopathic cytopenia or even low blast myelodysplastic syndrome, to consider all these categories, we should have 2% or less blast cells in the bone marrow. It's not 5% anymore, and this is the most important modification which have been identified in 2020. Another category or item have been again introduced in 2020, which is clonal monocytosis of undetermined significance, which might be a drive or pre-state in juvenile or adult chronic myelomonocytic leukemia later on, as we will see by the end of this presentation. So we need to have identification of each of these terminology. Idiopathic cytopenia of undetermined significance, idiopathic dysplasia of undetermined significance, clonal hematopoiesis of indeterminate potential, and the clonal cytopenia of undetermined significance. The ICOS is a peripheral cytopenia. We do have a cytopenia in the peripheral blood. MDS criteria are not fulfilled. MDS-related mutations are not found. No or less than 10% dysplasia in the bone marrow, and blast cells less than 5%, and in the new modification, less than 2%. In clonal cytopenia of undetermined significance, we do have peripheral cytopenia. MDS, again, are not fulfilled neither in the peripheral blood nor in the bone marrow, and we have blast cell less than 5 or 2%. Idiopathic dysplasia of undetermined significance, this term is not used very frequently nowadays. We do not have any peripheral cytopenia. MDS criteria are not fulfilled peripherally. We do not have MDS-related mutation. Dysplasia is around 10% or more, particularly of neutrophil or erythroid or megakaryocyte found, and the blasts are less than 5%. Wild shape is no peripheral cytopenia. MDS criteria are not fulfilled. One or more MDS-related mutation found, no or mild dysplasia, and low blast cell in the bone marrow. Idiopathic cytopenia of undetermined significance could be isolated anemia, isolated neutropenia, or isolated thrombocytopenia, and it could be a pancytopenia as well. So the idiopathic cytopenia of undetermined significance, or even the clonal cytopenia of undetermined significance, whether with or without a clonal transformation, we could have it in a single clone, either red blood cells, white blood cells, or platelet precursors, or we could have a pancytopenia. Now, what are the most frequent, as I said, mutations in the genes in the myeloid progenitors in the case of SHIP and clonal cytopenia of undetermined significance? As you see, and as we said before, the most prevalent is the DNA methyltransferase, and this is followed by TET2 mutation, and to some extent by JAK2 mutation. So these are the most important driving mutant genes which we are encountered in the phase prior to myelodysplastic syndrome. So what are these genes do to prevail these clones in the bone marrow? They increase self-renewal, and this is mainly derived by DNA methyltransferase mutation. They increase survival and increase inflammatory process, and this is mainly derived by TET2 mutation, and they decrease differentiation, and they are making genomic instability and genotoxic stress, and this is mainly derived by B53 mutation. So we are having major genes responsible for the most important characters making this clone winning and prevailing in the bone marrow, which is increased self-renewal, increased survival, and increased differentiation. So we have idiopathic cytopenia of undetermined significance, which has no genetic abnormality. We have clonal hematopoiesis of indeterminate potential, which is having just clonal abnormality without cytopenia. We are having clonal cytopenia of undetermined significance. We combine both cytopenia and genetic abnormality, and this could lead to myeloid malignancy. Idiopathic cytopenia of undetermined significance is the only abnormality prior to myeloid malignancy with no genetic or clonal abnormality, while all others are carrying a genetic background and a clonal abnormality. And as you see in the myeloid continuum of many malignancies, either dysplastic or destructive or proliferative, the end nightmare for all of us as hematologists is acute myelodysplastic leukemia. Now, if these SHIP or pre-myeloid or pre-MDS changes, are these varieties we spoke about are these accompanied by other disorders in the body, or what we call non-hematological consequences of SHIP? It has been documented that SHIP is associated with increased hematological malignancy, increased risk of atherosclerosis and cardiovascular mortality, and increased risk for therapy related myeloid malignancy, whether radiotherapy or chemotherapy, not only for hematological malignancies, but also for solid tumor. And this is done very early by the clonal changes we spoke about, and this will affect both innate immunity and non-innate immunity, and this will enhance inflammation, and this will enhance association with non-hematological disorder. And these non-hematological disorders include ischemic heart disease mortality, atherosclerotic cardiovascular changes, type 2 diabetes mellitus, increased incidence of venous thrombosis, hematopoietic malignancy, of course, chronic obstructive airway disease, and TET2 and DNA methyltransferase mutation have been observed in many CNS biopsies and CSF samples, and few reports about association with some CNS disorders have been reported, in spite that one recent very interesting paper showing that this might prevent or save the patient from having Alzheimer's disease. So we are having progression of inflammation plus the clonal from the pre-MDS inflammation up to high-risk myelodysplastic syndrome and acute myelodysplastic leukemia. What's interesting that in maybe 6 or 7 years ago, it had been observed that a higher incidence of vasculitis and immune-mediated like symptoms like scleroderma, Behçet disease, Hashimoto's thyroiditis, rheumatoid arthritis have been markedly and sporadically reported in association with myelodysplastic syndrome. In a very nice study, 100 patients of MDS, 42% are low risk and 58 are high risk myelodysplastic syndrome. In these 100 patients, 24% or 24 of them are having a very obvious autoimmune disorder manifested like a disease. So we do have a link between the autoimmune disorder and the inflammatory process with myeloid malignancy and even pre-myeloid malignancy. So we have to look for our immune system at the pathogenesis of the disease or contribution of occurrence of myeloid malignancy and as a potential for forthcoming targeting therapy. So the central role of inflammatory signaling in pathogenesis of myelodysplasia is established. This could be happening through the, as I said, epigenetic modulator, and you can see their effect on the innate system is mainly via cytokines, particularly IL-6 and others, and on the inflammasome signaling, particularly through the pyroptosis and B-catenins signaling. And this is also by spliceosome, the same pathway, either on the innate immunity or inflammasome. But here we can see that nuclear factor kappa-B manipulation or alteration or activation could have a contribution in such pathogenesis, and deletion of 5q also plays the same role either on innate immunity or inflammasome. And this innovated a new potential for therapeutic targeting for myeloid malignancy, and one of or two of these potential targeting are very interesting, which is the proteasome via manipulating the nuclear factor kappa-B, and we are now in phase 1 or 2 trial for such diseases, treatment of myeloid malignancy, and even ibrutinib, which again will work on B cell and will affect the cytokine release. So maybe in the future, we can see integration of B cell receptor inhibitors and nuclear factor kappa-B inhibitors. So what should we tell our patients if they are coming to us in the just a genetic background of the disease without any clinical manifestation, or if they are coming with cytopenia without still neither dysplasia nor hematological malignancy? I think we have to utilize the best of our molecular investigation for those patients, and we have to have what we call a teamwork or a multidisciplinary management of those patients. We have to involve cardiologists, cardiovascular medicine. We have to involve neurologists with us. We have to continue observing this patient, and we have to educate the patient and family and the medical providers and different medical specialists for such occurrence of combination of disorders in those patients. Treatment, we do not yet allowed or having a baseline for treating those patients in the pre-storm stage, but we do have to observe or to go for observing those patients and to clarify or to discover early as we can, stepping in any hematological or myeloid malignancy. The dose or the load of the variant allele frequency is very important, because starting from SHIP to clonal cytopenia of undetermined significance up to overt myeloid malignancy, you can see that we are shifting with more variant allele frequency. And the clonal metrics enable estimation of disease progression, and it might be the first thing to detect that the patient is high risk to enter into myeloid malignancy very soon. And this very much important to see if we have clonal hematopoiesis-like cluster with low risk of progression, or myeloid neoplasm-like cluster with early stage myeloid neoplasm that do not have yet developed full clinical phenotype, but we should be on guard because this patient might get into myeloid malignancy very soon. So we have a very good relationship between the variable allele or the variant allele frequency. If it is very low, it is SHIP. If it increases, we are in the clonal cytopenia of undetermined significance. This patient with SHIP is just having a genetic mutation. Clonal cytopenia of undetermined significance is having genetic mutation and cytopenia, mono or pan, while when we have a variant allele frequency high, we start to step into an overt myeloid neoplasia. Proposed diagnostic criteria for CMML dependent on the presence of high monocytosis. But recently, we start to have the new concept of clonal monocytosis of undetermined significance. And this clonal monocytosis of undetermined significance is equal to clonal cytopenia of undetermined significance. And these patients who are having clonal monocytosis of undetermined significance have been documented to have a higher frequency or a susceptibility, clonal susceptibility to progress to chronic myelomonocytic leukemia later on. More work is needed on this category particularly because this concept, as I said, have been published for the first time as assumption in 2019, and in 2020 this terminology have been accepted, and a lot of research work is undergoing now on the clonal monocytosis of undetermined significance. So we do have a confirmed relationship between the genetic, which is the platform of progression or occurrence of myeloid malignancy and myelodysplastic syndrome, and we have a solid fact now that we are having an immune background for the occurrence of myeloid malignancy. We do have a new hematoimmunological vexing disorder or disturbing or annoying disorder. This disorder have been first published on December 31st of 2020 in New England Journal of Medicine under the name of VEXAS syndrome. This VEXAS syndrome is occurring due to somatic mutation in UBA1, resulting into acute severe autoinflammatory disorder associated with some hematological malignancies. This VEXAS syndrome is usually associated with characteristic cytopenias or myeloid abnormality, but in the bone marrow, we have these vacuole in myeloid precursors in the bone marrow cells. The patients are having cartilaginous involvement either in the nose or in the tragus of the ear. Very well documented skin changes with neutrophilic dermatitis, which is very similar to sweat syndrome. Those patients might have infiltrate and pleural effusion, vasculitis of bronchial tree, neutrophilic alveolitis, and as I said, those are having hematological disorders. So VEXAS syndrome have been documented for the first time in December 2020, 25 men with somatic mutation, mainly in the UBA1 which is a chromosome present on X chromosome. Those patients are suffering from cytopenia, characteristic vacuoles and myeloid erythroid precursor, dysplastic bone marrow, neutrophilic cutaneous and pulmonary infiltrates, chondritis, and vasculitis. And most of those patients are presenting like inflammatory syndrome, and they are having hematological condition either in the form of myelodysplastic syndrome or few cases have been documented associated with multiple myeloma, or even both of them together. According to the ASH Clinical News few days ago, prevalence of VEXAS syndrome is too early to know to estimate the prevalence and incidence, while unfortunately the number of FDA-approved treatment is 0 up till now. In spite of that, a very interesting French experience with a single case of classic VEXAS syndrome with marked myelodysplasia with characteristic vacuolation of the myeloid precursors in the bone marrow and cutaneous manifestation and chondritis, extensive chondritis. This single patient have been treated with bone marrow transplantation successfully. So they gave us a very reasonable question. What are the limitations of hematopoietic stem cell transplantation in VEXAS syndrome? And they answered by that it can only be offered for young patients with limited organ deficiency. Now, what about the best timing for transplantation for those patients? And what is the best conditioning regimen for those patients? Is it a total bone marrow ablation, or we should do a reduced intensity? We need, of course, time to know how to treat those patients, particularly that the reported cases everywhere is showing a dismal prognosis in those patients. Is this still a long way for us to know more about hematological malignancy, myeloid malignancy, and what happens before them or in combination with them? Of course, we might not be there yet, but we are steadily going to be there in the near future. So my perspective concerning the pre-myeloid malignancies and the associated inflammatory and syndromes will be like that. In the past 5 years, sequencing technology have made our curious observation of clonal hematopoiesis to be a potential, to be a reality for a potential etiology and identification and even prevention of hematological malignancy. Knowing that we didn't achieve very much and survival have not been improved in AML, particularly in adult patients and MDS, we need to have something more to treat our patient, to observe our patient, to identify the disease as early as we can and treat our patient as soon as we can and with the best tool and the best target therapy. To achieve that, we need to know the mechanism by which certain clones can win in the bone marrow over age, the interplay between somatic mutation and different environmental processes and pressures and inflammatory process, the correlation of specific variants with propensity for disease progression is another very important task to understand properly to treat those patients in a very professional and very successful way. With that, I finish my presentation and thank you very much for your listening, and I'm very much happy to answer any of your questions. Thank you very much.